with Scott Allen.
Hello, I am your host, Scott Allen, and this is Phronesis, Practical Wisdom for Leaders. If the topic is leadership, I'm in. I've spent more than 20 years in the field teaching, learning, writing, and questioning. When I'm not working on Phronesis, I travel, delivering keynotes, working with individuals and teams, and helping people from organizations across industries become better leaders. Want to learn more? Visit me at scottjallen.net. Phronesis offers a smart, fast-paced discussion about all things leadership. We explore relevant topics and incorporate practical tips to help you make a difference in how you lead and live. Listen Notes lists Phronesis in the top 3% of podcasts worldwide. Phronesis is the official podcast of the International Leadership Association. ILA brings together those who teach, study, and develop leadership, advancing leadership knowledge and practice for a better world. Learn more at ila-net.org. Finally, if you enjoy Phronesis, please subscribe to stay current on our weekly episodes. If you find an episode that resonates, please share it with your colleagues and friends. And if you want more content, subscribe to my newsletter, The Leader's Edge. The link is in the show notes. As always, thanks for listening. And now, here's today's show. Okay, everybody, welcome to the Phronesis podcast. Thank you for checking in wherever you are in the world today. I have two physicians with me today. First, I have Dr. Jamie Stoller, and he is the chairman of the Education Institute at the Cleveland Clinic. He holds the Jean Wall Bennett Professorship of Medicine at Cleveland Clinic Lerner College of Medicine and the Samson Global Leadership Academy Endowed Chair. He is a pulmonary critical care physician in the Cleveland Clinic Integrated Hospital Institute. He serves as the Senior Associate Dean for Academic Affairs in the Case Western Reserve University School of Medicine. In 1979, Dr. Stoller earned a medical degree from Yale University School of Medicine and later completed an internship and residency at Peter Bent Brigham Hospital in Boston. He then completed fellowships in pulmonary critical medicine, Brigham and Women's Hospital in Yale, clinical epidemiology, Robert Wood Johnson Clinical Scholars Program at Yale, and Respiratory Intensive Care Unit of the Massachusetts General Hospital, otherwise known as Mass General, before joining the Respiratory Institute Staff at the Cleveland Clinic in 1986. I also have Dr. MinhTri Nguyen, and he is a graduate of Cleveland Clinic's Hematology and Oncology Fellowship Program. He has had leadership experiences serving as the Associate Director of Outpatient Services at Metro Health's Internal Medicine Department, Chief Resident, and President of the House Officers Association at Metro Health. This year, he was named one of Northeast Ohio's top 25 under 35 Movers and Shakers Award. MinhTri has a long-standing interest in emotional intelligence and leadership, with ongoing research in both subject matter as it relates to physician training. He is a certified coach, currently coaching resident physicians and clinical leaders. In the fall, he will be joining Stanford Healthcare, where he will be practicing hematology oncology with university medical partners while continuing his academic interests in leadership development for physicians. MinhTri, I think you were one of the first podcast guests I ever interviewed. This is back in 2012. I think you were president of the student union at Case Western Reserve. Am I correct?
Yeah, no, absolutely. My first podcast was with you. So it's the same experience. Yeah, that was back when I was student body president.
Oh, wow. And Dr. Stoller, it is so good to see you, sir. You are a long-standing champion of leadership within the Cleveland Clinic, and I'm excited for our conversation today. You know, before we begin, I think what I'd love to do is go with both of you. I would like to just talk about what's the source of your passion for leadership. It's so cool. You have these incredible track records within the context of medicine, but both of you have oriented at least, and there's some energy around this topic of leadership. And Dr. Stoller, maybe we start with you and then we'll go to MinhTri.
Sure. Well, again, delighted to be here, Scott, and to join you and MinhTri in this important topic. I've had a longstanding interest in healthcare leadership development, and it really stems from the perception of need in the end. My own journey, to answer your question, is a little bit serpentine in the sense that I didn't begin my career with a passion for physician leadership or physician leadership development. It evolved out of a series of somewhat serendipitous events, which I think probably describes much of the listenership of this podcast. In my own career, I've observed what others have called the arrival fallacy. What is that? You finish training. MinhTri is right on the cusp of beginning his career as an attending. I'm sure he, like I did earlier in my career, has a whole bucket list of boxes to check on things that he wants to accomplish as a budding, talented hematologist, oncologist, academician, et cetera. And, the details of the bucket list don't matter, but I found myself about 15 years into my career here at the Cleveland Clinic having checked those boxes. On doing so, I've experienced a sort of deflation of energy around even my own career. And your listeners don't know me, but I'm the least likely person imaginable to experience a deflation of energy. So with that said, it sent me on a bit of a journey to talk to colleagues. And I realized that all of my colleagues in a similar place in their career had experienced this phenomenon, but no one had language for it. And so I was referred to a colleague, now friend, then a professor of organizational development at the Weatherhead School of Management in Cleveland. Eric Nielsen is his name. And I went to Eric's office and described this phenomenon to him and became aware in that conversation that this was not idiosyncratic. It was quite expected that for knowledge workers like doctors, lawyers, engineers, professors, that we experience sort of a cyclicity of our career with mastery, and that mastery occurs in 7 to 10-year cycles. And that as mastery, and I don't want to sound immodest here, there's plenty of pulmonary critical care I've yet to learn, but the learning curve does shallow a bit. And as it shallows, there's a certain restlessness and desire to learn more. So I became aware that there was a discipline called organizational development that understood this, about which I knew nothing, actually couldn't have told you what it was at the time. And so Eric was running the master's program, and I said, you know what? I'm now curious. You have my attention, and the only way I'm going to learn this is to commit to an educationally accountable environment, like doing a degree, because if you put me in school, I know how to do that. And so I signed up, did a master's degree. The curriculum, as you well know, since you teach this, Scott, is informed by all of the elements of leadership. And so I finished that with a curriculum in my head, and then with an invitation from the Cleveland Clinic to start to develop leadership curricula. And that prompted me a little later in my career to actually be in a leadership position to find out whether I could actually do it or not. And so that was the source of my interest in serving in the role that I currently occupy, and I'm delighted to occupy as chair of the Education Institute, leading our efforts in education at the Cleveland Clinic. So that's my story, if you will, and I'm sticking to it.
Oh, that's wonderful. Well, and MinhTri, how about you? What is your pathway?
Yeah, Scott, thank you for having me. And it's always really nice to talk to Dr. Stoller as well. My sort of motivations in going to this, I think academically, I've always been really passionate about human behavior and studying human behavior. I find it just extremely fascinating. So, what happens in a certain situation that one person would choose one outcome and another would choose a different outcome. So there's sort of, I guess, interest in sort of studying human behavior and observing what one would do in certain situations. If you sort of scale that in leadership, I find it extremely interesting what we look at with, how one person can affect the overall behavior of many. And then the opposite, how many can over time affect the role of the leader. And so, the study between leader and follower and sort of the individual follower as well, I think that's what really drove the academic interest in all of this. So at the heart of it, it's human behavior. I think that's what drove me to major not only in pre-med and biology, but also psychology. I think the psychology of leadership is really interesting. Practically, I've always had a curiosity about leadership, particularly how change agents sort of affect our everyday lives and how one becomes a change agent. I came to the United States at a very young age and was thrusted upon a lot of change in my life. And I think because of that, I became really comfortable with change. And when I started kind of looking around me to see how other people sort of react with change, leadership was just a very obvious field to look at. And in undergrad, it's funny, I was talking to somebody about this the other day about how my trajectory in leadership kind of started. It started way back in 8th grade in junior high, when I ran for leadership positions, not really knowing exactly what leadership's all about. And then since then, ever since high school, undergrad, medical school, residency, et cetera, I've always sort of been, gravitated towards leadership roles. And I think part of that is just because I've been so comfortable with change. But it wasn't until undergrad where I kind of saw leadership as more of a study in a field that I could really get into academically. So I had great mentors. I met a lot of great leadership consultants, and I met you also, right, in undergrad, and I think that really spearheaded a lot of my academic interests in how we can take this into medicine.
Oh, that's wonderful. Well, I know that the two of you, you're embedded 24/7, 365, because that's when hospitals are open. You are embedded in this. And so I think for both of you, what are some opportunities you see for leadership education among physicians? What are the needs? I mean, I think you better than anyone have a really keen interest. And what I love about this conversation also is that Dr. Stoller, you've been in the context for a number of years, and you have your wisdom and insights into how things have shifted and what still needs to shift. As you said, Dr. Stoller, MinhTri is kind of beginning that process and looking up at a career. So I'm interested in hearing about what you both see. So what opportunities do you see for leadership education among physicians? MinhTri, maybe we start with you.
Yeah, I think there's maybe three things that I would say. One is there is an opportunity, I think, in medicine to start early. There's an opportunity, I think, to embed oneself in the learning of leadership in medical school, in residency, and continuously onward from that point. I know that this is sort of something that's been, talked about, and in some ways it has been incorporated into medical training. But that is an area of interest for me because I feel like that's sort of a lost opportunity that we haven't really capitalized on quite a bit yet. The next question then is, do we then call ourselves a leader just because we had medical school training in leadership? I don't think so. I think the practice of leadership, like medicine, both fields in their own right, are continuous. And so I think to be like a good practitioner of medicine, you need to not only be in tune with the practice, but you also need to practice medicine. So same thing with leadership. I think you need to be in tune with the field of leadership, ongoing, as well as practicing leadership. So my second point to this is that we need to have something that's continuous, leaders within the medical field, physician leaders. And that's something that I think comes in the form of like leadership coaching or consulting, or having someone who is really in tune with the field of leadership. You can do this yourself, obviously, that you can as yourself be in tune, but I find physicians are, strapped for time sometimes. And so we may not always have the time to always look onto other fields and make sure that we're up to date with that. The last thing I would say on this piece is it's great to incorporate leadership learning early, and it's also great to make sure that it's a continual practice. But how do we start, and what sort of foundation do we use to start? Because there's so many out there. Looking at the literature itself, I particularly am interested in sort of the emotional intelligent leadership model. I find that it sort of brings itself to the medicine field really easily. It's something that honors the sensitivity that's needed for medicine. I think it manages the stress and intensity of medical situations very well. There's a lot of studies that look at emotional intelligence and emotional intelligent leadership that have shown benefit not only for the physician in terms of burnout, satisfaction, but also really good for patients. It results in great patient-centered care, patient outcomes. And I think that this is something that we can teach early and is helpful in a multitude of ways, not only in just medicine, but I think for the person in general. So I think those are my three.
Awesome. Love it. Dr. Stoller, how about you? How do you think about that question?
Well, first of all, I want to underscore MinhTri's comments. I would respond, I guess, in the following way, Scott. I think the opportunities are legion. And, if I think about my own journey through this, in my career, medicine has evolved, and you alluded to this at the outset, from a sort of heroic lone healer model to a collaborative model. The concept of heroic lone healer was actually framed by my co-intern, Tom Lee. Dr. Tom Lee is now the chief medical officer at Press Ganey. Tom and I were interns together, and he wrote a paper in the Harvard Business Review in which he described doctors as the curriculum as heroic lone healers. And as I reflect on my own training, much better now, I hope, it was actually that we were trained to sort of be the patient advocate, be the bastion of knowledge on our patients' behalf. Was not taught as a team sport, nor were we selected for medical training or medical school as team players. I often reflect on the difference today versus then, and at least in our own medical school, the Lerner College of Medicine, it's entirely a team sport. And we are selecting medical students for their ability to be team players and to teach one another in a collaborative environment. So that journey frames the obvious need. which is that doctors, at least in the hidden curriculum, again, it's better now. The hidden curriculum is not one of leadership competencies around change management and team building and situational leadership and conflict resolution and all of the curricular attributes of leadership development. The hidden curriculum is often one of command and control. And so there is therefore a need, in my view, to actually unfreeze, using sort of Lewinian terms, unfreeze those early behaviors and refreeze a new set of behaviors that are very different than the competencies that make us great doctors or scientists. The way I think about the need is in three buckets. One, and this is framing work from the Center for Creative Leadership. One is teaching leadership curriculum. So people need to have a foundational understanding of many of the concepts that Dr. Nguyen alluded to. Change management, which is core to leadership, emotional intelligence, situational leadership, building teams, resolving conflict, all of which are deeply embedded in self-awareness and self-reflection, the emotional intelligence piece. The second is coaching and mentoring, so that having coaches that are available to you, that are supportive and nurturing, not acrimonious, because lots of feedback in medicine is actually acrimonious rather than developmental, if you will. And then third is experiential learning, the idea of being in leadership roles, learning from that, being accountable for that, and leveraging success as a leader to garner opportunities for greater and greater scopes of leadership. And I think careers in medicine and leadership are often punctuated by that sort of trajectory. You're asked to chair a committee, you do a good job. You're then invited to chair a larger organizational activity. You're then invited to be a department chair or division chair, and then perhaps, a dean, or then a CEO, et cetera, et cetera. These are progressive leadership roles predicated on success in the prior role. So to answer your question succinctly, they say lung doctors are long-winded about the short-winded, and I'll try to belie that reputation. But I think the short answer is that there is an incredible need. And front-running organizations in healthcare, and I'm pleased to think that I'm part of one, the Cleveland Clinic, front-running organizations are deploying such curricula in service of developing leaders in their healthcare providers, not just doctors, but interprofessional curricula.
Well, and if you think about it, I mean, your three elements right there, curriculum, coaching, and experiential learning. I mean, if we were trying to develop a physician, it would seem that those would be three core ingredients: a strong curriculum, some experience. You don't start with a heart, you start with a gallbladder. So we've got, experiential learning, we've got the curriculum, and we've got coaching along the way, and then kind of escalating levels of authority or scope that the individual is then prepared for.
Yeah, I touched upon this a little bit about the continual need for someone to, either you yourself or someone who's in tune with the field, to make sure that you are, I guess, up to date in your leadership sort of knowledge or whatever. And I think this is kind of true to what medicine is as well. Medicine as a field has sort of evolved through time. So we don't treat patients the way that we used to treat, because at that time we knew differently. Now we know that we treat, in a different way. I think leadership also started off in the same sense, right? We used to think leadership was something that you were born with, that it was intricate to, a male figure and all this stuff. But we now know, I think, through a lot of studies and through a lot of just trial and error, that these sort of previous thoughts about what leadership is, these previous thoughts about what medicine and treatment used to be, no longer is true. And so to me, what's most important out of all of this is that if you are a leader, you have to have a continual, I guess, passion for renewing your knowledge base that can then transpire to practice. And so that coaching component, I think, is particularly important if you yourself are not already embedded in the field.
Yeah, because that learning, to your point, how we treated the course of care in 1980 was very, very different than it is in 2024. And the course of care probably, was not as effective as it is in 2024. And so that continuous learning, Dr. Stoller, I know you want to jump in there. What do you think?
Well, I was going to underscore, I guess, again, what Dr. Nguyen said. The way I think about this is through the lens of a spiral curriculum. And that as one teaches leadership to medical students, their needs and their lens is very different than the lens of a resident or a fellow or an early attending or a more senior attending. And so while the curriculum is the same, you think about it through the lens of emotional intelligence, self-awareness, self-management, relational awareness, and relationship management. Medical students are much more, as they should be, self-absorbed. They're trying to figure out learning a complex body of material, and they're less focused on their interface with the organization, as they should be. On the other hand, as one becomes, for example, a chief resident, that's a pivot point in which you're pivoting from a focus on self-growth to an early leadership responsibility for a group of colleagues, trainees in a training program. This is why, for example, we at the Cleveland Clinic had run for now 16 years a chief residence leadership workshop, which we take the chiefs offline, and they recognize that this is not Kansas anymore, that their roles and responsibilities are a little bit different than being, the individualistic, capable doctor that they are at that point in their careers. And as one then emerges from early training into early attendinghood, if that's a word, then one interfaces with the organization. You're on committees. You're now a change agent of scopes of greater and greater responsibility. And there, the spiral curriculum is much more focused on relationship awareness and relationship management, and some of the competencies that appear in the lower right quadrant of the emotional intelligence map, if you will, about situational awareness and service orientation to the organization and altruism. And so these competencies evolve as the needs of the learner evolve. And to Dr. Nguyen's point, this should begin and does begin in our institution in medical school, but the content of the learning changes over time because the stickiness of the learning and the needs of the learner change over time, if that makes sense.
It's like precision medicine, right? We're so used to making sure that it's patient specific. Well, I think this is leader specific.
Well, I think the two of you are hitting on something that I've been reflecting on recently. As I have conversations with people from all over the world every week and put those out into the world and get feedback on the episodes and such. It's so interesting to me because, well, you could look at some domains like, let's just go with the military, or you could look at a domain like healthcare. And let's just look at developing a physician for now. And Dr. Stoller, I think you said this beautifully, but in leader development, we don't always scaffold it well. So even karate has figured that out, right? Hey, we're going to start off with a white belt. And my equivalent from a leader development standpoint could be something to the effect of, have we started with active listening? Are you skilled at active listening? I mean, we need to stack some of these behaviors and make them age and stage appropriate so that as the individual develops and moves through the organization, we've actually truly built some knowledge, but also built some skill. And again, in medicine, I think we're very, very, very seasoned at how to do that from a care standpoint. That education in the College of Medicine at Lerner, I imagine, is very well mapped out. I don't think we do that well in leader development. We have faculty members and colleges entering the conversation at systems thinking, at chaos theory. That's black belt content, right? That's when you're a little further along. But it's this huge hodgepodge of mashup of concepts and content that it's kind of a messed up dojo where you never really know where you're going to get. And we never really know what you're going to get. All important topics, but often not age and stage appropriate. Now, I know both of you have some reactions. MinhTri, you want to jump in?
Yeah, real quickly. But this is the basis for one of my academic research projects, as Dr. Stoller knows. I study emotional intelligence and emotional intelligent leadership in medical trainees because I believe that it is a scaffolding for leadership. It is a foundation that I think we can use. And part of my research looking at the literature is surrounding what sort of interventions or what sort of research academically has already been done in this field. And through my, just quick overview of everything, it seems like we're very quick on taking like interventional type of, needs. So a lot of the studies that have been done on trying to increase emotional intelligence have been just that. There's really no study prior to that knowing what happens with emotional intelligence, even within medical training. No one has written about the trends of this. We don't know if medical trainees actually lose emotional intelligence throughout their medical training. We don't know if it actually increases or at what point it actually gets, higher or lower. So part of the study that I'm trying to look at is well, maybe we should kind of work a little bit backwards here and kind of see what are the needs before we start intervening. Because like you said, it's just a hodgepodge of a lot of interventions that we don't actually have really good basis for yet.
Yes. Yeah. And as Dr. Stoller so beautifully said, you might be defining spiral a little bit differently than I am. I'm saying scaffold, but it's appropriate and it builds upon, and it's not just the knowledge, but there's knowledge, there's skill, there's experiential elements of all of this, so that we're in this consistent space of learning, growth, and development that, again, builds upon where that learner is and is appropriate. At times, I'm in the classroom and we're teaching the students concepts that won't be applicable until they're 28, 30 years old. And what are we doing? Dr. Stoller, what do you think?
I was going to sort of add to the conversation about scaffolding or spiral curriculum in the following way. And I think there's a funny nuance in medicine. First of all, I agree with both you and Dr. Nguyen that emotional intelligence is foundational. One of the components of emotional intelligence, as you pointed out, Scott, is active listening. And here's the nuance in terms of teaching leadership to doctors. Every physician in medical school learning to take a history is trained in active listening. We paraphrase. The patient comes, I'm a lung doctor, patients come and see me who are short of breath. And Mrs. Jones might say to me, Dr. Stoller, I'm becoming more short of breath over the last 3 months, particularly in climbing stairs. And at some point in the interview, I, like every doctor, would paraphrase that. At some point would say to Mrs. Jones, so Mrs. Jones, I understood you to say that you've been getting more short of breath over the last 3 months and climbing stairs. Is that correct? And of course, that is the quintessence of active listening. I paraphrase in service of two things, making sure I'd heard her and making sure that I got it right. Now, the paradox here is that while every doctor learns active listening, they practice active listening in a clinical context. But when we take doctors out of the clinical context and put them in a committee meeting, it's the antithesis of active listening. They're not active listening to each other. And in fact, I've often likened meetings among doctors, I can say this as I am one, not to be disparaging, but it's often like a Viking dinner in which, there's warring dialogues, to use David Brooks' term. People are censoring sentences, cutting each other off. There's no decorum on active listening. And so the point I'm trying to make is that as these competencies are scaffolded or spirally developed in medical students, what we have to do is connect the dots so that the competencies that we use in clinical medicine actually apply to non-clinical leadership contexts. And the other point to make is that doctors are all evidence-based animals. And my experience of the evidence that provides sort of an inflection point or a call to action for their own behavior is seeing their own behavior, not hearing evidence articulated at a high level, but seeing their own behaviors and then using feedback on their own behaviors as a predicate for changing the behavior. That's where coaching, that's where experiential activities come in as part of the pedagogy of leadership development. I'll stop there.
That's great. Well, Dr. Stoller, you've been at this for a while. And I think what I would love to hear from you is, what do you know, quote unquote, about developing leaders? After this, you've been doing the work for decades, and it's incredible.
Well, what I know is this, as with all things, we have more to learn. But what I know today is that, number one, this is important work. Number two, that organizational success, and healthcare organizations are organizations by their very nature, that organizational success requires great leadership, that great leadership is a team sport. I know that front-runner organizations in healthcare have committed to developing curricula and offering leadership development to healthcare providers within the organization. I know that this is best done interprofessionally, not just doctors, but doctors, nurses, allied health professionals, all working together and learning together because, again, the practice of medicine is an interprofessional and multidisciplinary activity. I also know that as individuals join organizations, because most doctors are, in fact, joining organizations as they finish their training, very few are going off by themselves into private practice as an individual, that organizations, in order to recruit and retain talent, must provide developmental pathways for people in the organization, whether it's developing as a scientist, developing as an educator, developing as a leader. And so offering leadership curricula and programs intramurally within organizations is a very important recruitment and retention strategy for talent.
Well, and Dr. Nguyen, as you look at your career, and again, we know that you're focused a little bit on emotional intelligence and that that's a passion for you. What else are you kind of observing as needs in the healthcare context? What else stands out for you as opportunities that we're missing right now?
I think I'll speak about just in general what leadership can do for physicians. And the approach can be, EI, emotional intelligence, or it can be other sort of leadership styles. My thought on this is it comes from, I guess, my hope of what healthcare can be. I really truly feel as a new, early career physician that physicians enter the field of medicine for all really good reasons, altruistic reasons, humanistic reasons. I think many of us, particularly since the pandemic has really brought this out, a lot of us are starting to feel sort of dissatisfied and less fulfilled in these roles because we find that when we do enter sort of the working years of our physician roles, there's a bit of like dissatisfaction and disempowerment within the role of being a physician. And I think with the hope that I have for sort of embedding leadership within physician is that we sort of, in some ways, take back the field of healthcare in certain ways, be it within an organization, be it within ourselves individually, because I think we get so inundated with learning the medical parts of our work that we lose sight of these other skill sets that ultimately end up being very important for us to run healthcare, which has grown to be such a beast that it's not just about the clinical work anymore. It is about what Dr. Stoller had said, managing teams, working with multidisciplinary people, non-clinical people. And so my hopes is that if we do sort of pump more of this leadership learning into a physician's life, that in the grand scheme of things, the big picture of why I love doing this work is that it will hopefully empower physicians to not relegate ourselves as like a cog in the wheel, but eventually empower us to a point where we can push healthcare and push it to a point where we remember it to be what we entered healthcare as, a bit more humanistic.
I agree with that. I think staying close to one's roots and the initial impetus to be a doctor, to be reminded about that over the course of a complex career that gets invaded by many other complex agendas, all of which are important, but which can cloud, one's initial appetite to be a physician, I think is very important. We know, for example, and this has been studied and published, the Jefferson empathy scale, that empathy characteristically among third-year medical students starts to decline. And that's precisely the time in their career when they get immersed in hospitals and on call, and they're tired and they're stressed, and the reality of being a doctor starts to impose upon them, beyond biochemistry and pathology and pharmacology, et cetera. And so that's a perfect example of what Dr. Nguyen is talking about. And I think that sort of going to the balcony, if you will, and taking a look at oneself periodically, often with a coach, for example, can be very helpful to reminding oneself about the reason we're doing this to begin with and what we're here for. But that requires leadership and teams and awareness of the competencies, as we've been saying and discussing in this conversation, that are overlaid on top of being a really, really, really good doctor, right? It starts with being a really, really good doctor. And leadership, at least in my institution, and I suspect in most, being a candidate to be a leader is predicated on your commanding clinical respect of your colleagues. That leaders aren't selected because the candidates are deemed not to be capable as doctors, and therefore, why don't we give Jamie a leadership opportunity? I think that leadership is predicated on commanding the respect of your colleagues in your primary role, i.e. being a doctor, but recognizing that the attributes of being a great doctor are insufficient to make you a great leader. And that's the fundamental thing that we've been talking about here. And so on top of having developed oneself as a really solid clinician, one then needs to take on this extra agenda of learning leadership competencies, if that makes sense.
It does. And I was having a conversation with a person this morning, and we were talking about how leadership today is exponentially more complex than maybe it was 40 years ago. That's for any number of different reasons, whether it's globalization, digitization, multiple generations in the workforce. And I oftentimes will say, and Dr. Stoller, I think I've said this to you, I can't think of a more difficult context to lead in than healthcare. From a day-to-day, maybe in wartime, that's more challenging. But in a day-to-day, I'm just going to work. I can't think of a more challenging context to lead in than healthcare, which to MinhTri, your point is that, you know what, we need to ensure that we're doing this work and we're doing it well, and we're preparing these people to serve in these roles. And Dr. Stoller, what you just said really stood out for me. Look, we need to make sure that they're experts in their craft first. And then it's almost like you have to take a step back, check the ego, and you have a whole new mountain to climb when it comes to this work of how the hell do I get work done through others and with others in a very, very complex setting, where many of the approaches and the knowledge that I have in this setting, kind of that lone wolf, doing it myself, studying hard, a lot of that, it's not going to serve me well in this new role, in this new context. And I'm going to have to, in many ways, be ambidextrous. Does that make sense?
Perfect sense.
I want to highlight what Dr. Stoller had mentioned about how physicians are promoted to their leadership roles based on clinical acumen oftentimes. And he writes about this wonderfully in his call to action. And I think it's sort of a double-edged sword too, right? Because what happens is if we forget about leadership training earlier on, then we run into that situation that you're talking about, Scott, where you do now, when you're in that leadership role, you almost have to forget all of your lone wolf training and then learn a new subset of clinical or leadership skills that you never heard of before. So the double-edged sword there for an organization is, one, you just lost a really good clinician, one of your best clinicians, actually. That's the reason why they were promoted, because now they have all this work that's not clinical. They're not doing their clinical work anymore, or maybe they're doing less of it. And so not only have you lost a really good physician, you've earned a really bad leader. So it's a double-edged sword. You're losing on both sides. So my argument to all of this would be that we start leadership training early, because then, yes, you get to that point, you do lose a little bit of your clinical work, but you actually still had some of that leadership work prior to being in that new leadership role. You don't have to start from scratch.
Yeah. And we don't lose on both ends, like you just said.
Right.
Wow. It's a beautiful puzzle. And I have great respect for the fact that you are working the puzzle, and just love this conversation because, my passion is how do we better prepare people to serve in these really challenging roles? It's not easy. It's not easy. It's very, very difficult. And at times in organizations, I don't think we do a good job of that work in all kinds of contexts. But healthcare is a fascinating context. And in many ways, I think prepared to do the work better than many organizations, because there's a lot of structure and there's a lot of hierarchy and a lot of learning and continuous learning that exists. So I just have great respect. Well, as we begin to wind down our time together, I would love to know what's caught your attention recently. And so I always end these conversations by saying, what have you been reading, streaming, or listening to? It could have something to do with what we've just discussed. It could have nothing to do with what we've just discussed. But maybe Dr. Nguyen, what has stood out for you recently? What's been catching your attention?
This is really funny. This will at first seem like it's not connected, but I think it is. So I started taking a course on Coursera. It's a free course. It's on AI. It's due Andrew Ng, NG, from Stanford. He does like a free course on AI. And the reason why I did this, and this is kind of funny because I was talking to a friend the other day, we kind of joked about it. It seems like everywhere I go, be it a conference or a lecture or anything where there's a speaker talking, it just seems like when it gets to the question and answer session, someone always inevitably raises their hand and asks about AI and how it will affect that presentation topic, whatever it be. So it's always a joke that I'm just like, if you don't know what to ask, just ask about AI. So that's sort of my running joke. But I'll be honest here, I think there is a connection here to what we're talking about. And that is that I see technological advances in our society. We can see it as one thing as physicians. We can see it as like a threat that these technological advances can take over our duties and our roles as physicians. Or we can see it that these technological advances really, I think Adam Grant said this at one point, it really places a premium on interactions and relationships that we have with each other. And so the soft skills that we learn in leadership training, emotional intelligence, things like that, the things that really make us human, I think that's what's going to be becoming really increasingly important for us to master as physicians because of the technological advances.
Dr. Stoller?
It's a wonderful question. I guess my passion is really anchored in high performance and organizational effectiveness. And so much of what I read and think about is that particular lens around this based on work that I and several co-authors have published on virtue-based leadership, that when one creates environments that are anchored in the 7 classic Aristotelian virtues of trust, compassion, hope, justice, wisdom, temperance, etc., that unleashes discretionary effort in the organization. That's where high performance comes from. So in that regard, I avidly read David Brooks. One of my favorite pieces of his is called The Moral Bucket List, in which he talks about resume and eulogy virtues. We've written on this several recent books. I don't want to sound like self-promoting, but the work on Better Humans, Better Performance, which is a book that Dr. Peter Ray and Dr. Alan Culp and I have co-authored, I think is our attempt to try to make sense of this across multiple sectors. And MinhTri has mentioned Adam Grant. I love his work, Give and Take. I've recently finished his book, Hidden Potential.
Yep.
Selecting talent on the basis of its trajectory. It aligns very well with our holistic view of interviewing for medical students and trainees and residents. And then lastly, I guess, there are two talks that are on YouTube. One older by Don Berwick, his commencement address to the Yale Medical School, maybe 5-10 years ago. It's just amazing. I won't even attempt to summarize it. And then more recently, Ken Burns' address that was a commencement speaker at Brandeis University this year. I think he delivered what I would regard to be an incredibly articulate, brilliant presentation to the graduating class of Brandeis just several weeks ago. So those are the things that have recently caught my attention.
And I will put links to all of those resources into the show notes. So a book for the two of you that has caught my attention in recent times, Stephen Kotler, The Art of Impossible, Kotler, The Art of Impossible. Absolutely incredible. And so he is extending on the work on flow and how people enter flow states. And he has studied world-class athletes and just fascinating. I listen to it, or read if that's what you choose to do. Well, Dr. Nguyen, Dr. Stoller, thank you so much for joining me today. I really, really appreciate your time. And thank you for the incredible work that you're doing. You are exploring and making the world a better place on a few different fronts, and we appreciate that. What an important conversation with Dr. Stoller and Dr. Nguyen. I just really, really appreciated their time. And for me, the practical wisdom is that we need to scaffold the learning. We need to more effectively scaffold the learning so that it's appropriate for state and stage. And by doing so, we have a better shot of truly developing leaders. And it's not just their knowledge. It's their knowledge, their skills, their experience. No different than if we were trying to create a world-class surgeon. Who does it best? I think right now, probably the military does that the best. Are they perfect? No. But I think that's one place to look for clues as to how we can do it better. To all of you, thank you so much for checking in. To my good friends, the doctors, thank you, gentlemen. I really, really appreciate your time and can't thank you enough for the work that you do. Take care, everybody. Be well. Bye-bye. You have just finished another episode of Practical Wisdom for Leaders with Scott Allen. To contact me, visit scottjallen.net or send me a note at scott@scottjallen.net. I'm also on LinkedIn, so let's connect. If you have feedback, I'd love to hear it. And as always, thank you so much for listening. And now here's my daughter, Emily, with the outro.
You've been listening to Phronesis, Practical Wisdom with Scott Allen.